And so I am going to start always in the zero position, as I call it. Your notch will be pointed towards the patient's head. The base of your probe in the longitudinal plane will be towards the patient's feet. I am going over, and I can palpate, even in patients that have a pannus, their symphysis. So this gets me right at the isthmus of the cervix, and you should see anterior to posterior, the patient's bladder, and the patient's either their vagina or their cervix. So it depends on how many times, and if your patient has ever had a baby, the size of the uterus, if there's any pathology within the uterus, as to what you're seeing. And I always start transabdominally because it gives us a global view of what's going on with the patient's pelvis. For example, if their uterus is very large, and how helpful and beneficial an endovaginal scan will be. If a patient has a uterus that's full of fibroids, for example, it will be more difficult to penetrate as fibroids are denser than normal uterine tissue, and it will make transvaginal imaging challenging. But if I already know that ahead of time, then I can get the information that I need transabdominally and then augment the study with a vaginal ultrasound. So as I'm looking at this screen, I see right away that this patient's uterus is very heterogenic. It is of different and differing echo textures, which is leading me to believe initially that she may have multiple fibroids. I see several, one specific large one here, there's another one here. You can see the bright echogenic line, which represents her endometrium, and the posterior wall, which is down here, of her uterus. Now this is all very dark because, again, fibroids are very dense and it causes shadowing on ultrasound. So there's a couple of things that I can do with the machine to manipulate that and try to increase my penetration and the clarity of the image. So what I'm going to do is decrease the frequency. Decreasing the frequency will give us more penetration. We will lose some in the definition and our echo texture. The image quality will degrade slightly, but we want to see all the way through the whole uterus, through the whole gland that we're interrogating, or organ, so that we can make sure that we are imaging the whole thing in its entirety. Now, because this patient has a fibroid uterus, her uterus is enlarged. Most women's uterus, and this patient has been pregnant multiple times, it should go back anywhere between 9 and 11 centimeters. But with the fibroids, as we measure, and I'm just doing a simple two-dimensional measurement to get the length, her uterus, even though it's got multiple fibroids, and we're going to include the cervix in the measurement because the cervix is actually part of the uterus and not independent from it. If I were doing a volumetric measurement for the uterus itself, I would exclude the cervix. But in this case, I just want to see the overall length to give me an idea of how beneficial my vaginal scan will be. And so we're getting her longitudinal and and bisecting that with the anterior posterior measurement. The longitudinal measurement is about 13.2 centimeters and the AP diameter is 8.6. And I will get a transverse measurement, meaning I have now turned my transducer from the sagittal plane. As you can see, I did not move my transducer up, down, side to side. All I did was go from the 12 o'clock position to the 9 o'clock position, just simply with a flip of my fingers, so that I will get a cross section of the organ. And now I will do a transverse measurement, and that gives me a measurement of 10.8. So the overall volume of her uterus, or measurement, average is about 11.5 centimeters. Now I will measure the whole thing with the measurement package, and it will actually give me the uterine volume. We can go over here on this system and label what we're interrogating. In this case, we're looking at her uterus. I am back to the 12 o'clock position. I am in the sagittal plane. I'm going to put these measurements now into the measurement package. I have it set up to auto calculate, and it comes up immediately here with length. And so I'm going to do that. I'm going to measure the length of the whole thing again. Because I want a volumetric measurement of the uterus, I'm going to exclude the cervix. I'm going to do the AP diameter, which is 90 degrees to that longitudinal image. I'm going to turn my transducer again from the 12 o'clock position to the 9 o'clock position and get the maximum width. So I'm mid-uterus, and my caliper automatically comes up, and I'm going to do the right to left measurement. And that gives me a uterine volume of about 476 cubic centimeters. I'm going to change the label on my scan because now I am in the transverse plane or axial plane, and take that image. I'm going to clear it, and I'm just going to peruse her uterus. So I'm in the transverse plane. I'm going to angle the probe. Again, I'm not moving my probe all around like this. I am still in the 0 position, and I am going to locate the urinary bladder, which is right here. We're going to turn down and adjust the gain so that the fluid that we know that's in the bladder, which represents urine, is black. We're not going to turn it down so much that we obliterate the tissue surrounding it. So we can use our overall gain, and we don't want it also so bright that it puts particles in the bladder. We want the bladder black, and we want the soft tissue to represent soft tissue. So I'm angling in the transverse plane towards the patient's feet. I can zoom my image, and you want your focal zone at or below the area of interest. In this case, what we see here, again, I'm in transverse, so my transducer is 90 degrees. This is the patient's skin, so this is anterior, this is posterior, patient's right, patient's left. So what I should see, we see the patient's anterior abdominal wall, the rectus abdominis, we see some valve, we see the anterior portion of the bladder, the posterior, and you can actually see the dip as it goes in towards the urethra of the patient, and this is her vagina. This is the anterior portion, this is the endovaginal bright canal here, and this is the posterior aspect of the vagina. We label that by saying transverse vagina, and we can abbreviate simply VAG. Now I'm going to go and do the uterus and the transverse, and I'm going to sweep from the inferior portion to the superior portion until I'm completely out of the uterus, past the fundus. So this way, we're going to, because she has these fibroids, I'm having to move my transducer over. I have no full bladder to use as a window, so I'm moving my transducer over here. You see all of this dirty shadowing, it's all bowel. So I'm going to come across the other side, and I'm going to angle back towards this patient's cervix. And here we are. This is the mass of her uterus here, which is mostly fibrotic at this point. And so this is what we immediately see because her bladder is not full, and so the uterus curves up like a pear that has been bent over the top of her cervix. So we see pretty much the main body of these fibroids in her uterus before we can get to the cervix. Now I'm putting quite a bit of pressure on her belly in order to, if I don't put pressure, we don't see anything. If I increase the pressure, it clarifies this image. So now I can see the uterus, but what's more important is I can see a distinctive anterior endocervical canal and posterior portion of the cervix. So this is transverse uterus or transverse cervix. Transverse cervix. And in this case, because she's got these fibroids, I'm actually going to put arrows on here so that somebody that is looking at this will understand what I'm trying to demonstrate. Remember, in ultrasound, as a sonographer, we are trying to tell a story by giving representative pages to the book so that by the end of the images, they'll have the whole picture or the whole story. The person that is interpreting your images generally don't have real-time images to help them, and so we have to provide a full and concise story. And I'm just going to sweep and take. I've already taken my measurement, so there's no need to do that. I'm going to increase my gain again so that I can see the echo texture of these heterogenic masses that are within her uterus. And now I'm scanning all the way out. Now I'm in BAL, and I'm just going to come back till I'm just into the superior portion of the uterus, which is the fundus. I could attempt to measure all of these fibroids, but I won't. When I do the vaginal ultrasound, I will just measure the largest ones and try and locate them. This is just a general ultrasound. I am not doing a fibroid mapping. And now I'm sweeping my transducer in the transverse plane because it's the only way that I can globally see the uterus and the adnexa. We're going to look for her iliac vessels, and you can use color to augment this to help you out in the search. Whatever you're going to call ovary needs to be between the lateral uterine wall and the iliac arteries. And as expected, I don't really see her ovary on that right side, and now I'm going to sweep over to the left and repeat the process here. Again, this is the iliac vessel, the artery and vein, and whatever I'm going to call ovary needs to live in between here, the lateral uterine wall, this space, and those vessels. But I don't see them, again, because she has these multiple myomas, or what I'm calling myomas, making scanning a bit difficult and challenging. Right there we can see as I push on her belly, this is probably her left ovary. As you can see, the bowel here is peristalsing. I'm still in transverse. This is the lateral uterine wall. The bowel is peristalsing. This stays here. This stays the same. It's slightly hypoechoic to the uterus, and we can see the traditional chocolate chip appearance of the follicles on the ovary. Now this patient is postmenopausal, but it's not uncommon to see follicles even in the postmenopausal patient. And I'm just going to label uterus and the ovaries. Again, I'm still transverse, and I'm going to call that left ovary. I'm not measuring it because it's low enough, and I should be able to see that when I do the transverse or the transabdominal or transvaginal imaging. And that's it for the transabdominal portion of this exam. I'm going to sweep till I'm all the way out in transverse. If the patient were having any pain during my exam, I would ask her to tell me exactly where she is hurting, point to it, and I would scan that area. The top of her uterus at this point in pregnancy, she should be 18 weeks and 3 days, is at around the umbilicus. Sorry. I'm going to start again at the 0 position and interrogate this patient and get fetal situs. Our only known is mom, and so we know that baby can be in any position that they want to be in. So we're going to take a picture of the lower uterine segment and show the presenting part of the fetus if we can. So what we should see moving anterior. This is the patient's anterior abdomen. This is posterior. This is towards mom's head and towards mom's feet. So the top of the uterus is up here. We're just going to do a little survey. And as stated, this is patient's umbilicus. We can see as the shadowing through the belly button, and the uterus is just superior to that. This is the patient's aorta thumping, and we see baby's feet. So this is anterior uterus, posterior uterus. We see that the baby is head down. Head is oblique, looking sort of to the anterior portion of the uterus, but this gives us a lot of information. We see here is the base of, or the posterior portion of the cervix. This is vagina. This is mom's urinary bladder, the anterior uterine wall, and the posterior uterine wall. And this is the placenta. The placenta is way away. This is the internal os here of the cervix. And as you can see, I'm not moving my hand very much, but we can see that the tip of the placenta is away from the internal os of the cervix. We can confirm that there's no kind of vasa previa or anything just simply by putting our color Doppler on and making a quick sweep to make sure that there's no vasculature between the placenta and the cervix. I can further interrogate the placenta. I'm going to decrease my depth so that I can isolate just the placenta, and we can see very clearly, even in grayscale, the cord insertion. And we want the cord to be someplace in a nice thick portion of the placenta. In her placenta, the superior tip of it goes all the way to the fundus. Now we can confirm the location of her placenta by going 90 degrees. We were at 12 o'clock and now we're at 9 o'clock. Again, we can see the cord inserting into the nice thick portion of the placenta, and there is nothing anterior, it's all posterior. So this would be called a posterior placenta. And if your facility needs to grade it, it would be a grade 0 because we have nice uniform echoes throughout the whole gland. As we know, the placenta is an organ that is grown specifically for one purpose, and it's the interface between mom and baby. It is the toilet, the food supply, the filter, everything. It's an endocrine gland that has a finite shelf life. And what we want is that cord to insert in a nice thick part and not be extrinsically placed. We do not want a velamentous cord insertion. If we do, you want to make the managing physician aware of that fact, because the placenta, as it gets older, can become a little atretic, and what might be eccentrically placed, the cord insertion, might then become a frank velamentous, and it may lead to problems during delivery. So they might manage the pregnancy a little bit differently, or be more conservative. So we see here, because again, mom is the only known that the head is down. So this is a vertex presentation. So we have a vertex presentation, and we're going to label it. And why do we care about vertex presentation is because this is where we get fetal situs from. And then we're going to also label, and you can do this all in one shot. We'll just do something like this, where we put sagittal placenta, and we can actually go posterior placenta. And again, we don't care where the placenta is as long as it's not covering the cervix, and the cord is where it should be. We can take the color off, and as you can see, in this case, in this patient who scans very nicely, we can even see in grayscale. We don't even need the color. I'm going to change the orientation because I've gone from the 12 o'clock position to the 9 o'clock position, and we are going to label that transverse posterior placenta. And there we go. Now, what we're going to do, and one of the most, if not the most important thing to do when you are scanning your patient, your fetus, is to determine situs. So this baby's head is down. If I am 90 degrees, there's both orbits. And as we can see, within the orbits of this fetus, we see these two little round, beautiful, look like bubbles. And those are actually the lens of the fetal eye. In this thing is very subtle, but in this we can rule out quite simply congenital absence of the fetal lens, which is how babies can have, or some children can have, congenital blindness. And we've just ruled that out just simply by looking for it. But what we're doing here primarily is to get situs. So we have the head, and we see that the baby is turned when I go from 12 o'clock to 9 o'clock, that the baby's head is turned as we go to the orbits, and it's actually looking out mom's left side. And so that means that the spine is at 9 o'clock, the orbits are like around 3 o'clock, and so that means that the fetus, when we go down to the fetal thorax, we should come across the beating heart, okay? And it should be at the top of our screen, and this one is. So this, we say, is situs solitis, meaning it is where it belongs. The situs of the fetus is correct. And we can go further down, and when I say down, I mean inferior to baby. Just because now that we have established situs, we know that the baby is laying on its right side with the left side most anterior. So inferior to the fetal heart, I should see fetal stomach on the left. And here we have. Now we can go on a coronal shot of the baby. And in one image, one longitudinal image, we can see the fetal heart, the fetal stomach, both on the left side, a diaphragm going all the way across, and then the fetal bladder. So that lets us know that everything is living exactly where it belongs. The heart is in the chest, the stomach is in the abdomen, the bladder is in the pelvis. We can further evaluate the diaphragm as it goes across the liver. We want to make sure all organs are in their proper compartments to rule out things like diaphragmatic hernias. We want the bowel to be slightly echogenic, but not more echogenic than bone. And we can turn it down, and we can see here that it's not. They're about equal. Actually, the bowel is a little less echogenic than the bone, so that's normal. Echogenic bowel is a soft marker for Down syndrome in some cases. We can follow this, and we can see the fetal aorta. But primarily we're doing this to establish situs. And we'll start our measurements. Since the baby's head is presenting, I will start here. Now, at this point, I am not paying attention at all to whether I'm longitudinal or transverse with my transducer. I am making sure that I am longitudinal or transverse to whatever it is that I'm interrogating on this fetus. In this case, I'm going to try and look at the baby's head and measure the posterior ventricle of the baby. We measure the posterior ventricle because it is dependent, and we can see it much better as just the normal, the way the ultrasound works. As it hits a strong reflector like the fetal skull in this anterior portion, it's going to bounce back and forth between the transducer and the fetal, the hard part that it hits. And so it makes us able to see the downside, or the ventricle most posterior, clearer. So this is what we're going to measure. I'm going to hit the calculation button because I want this measurement to go into the fetal package. I'm going to select fetal cranium. I'm going to select VP on this system, Some systems say lateral ventricle, anterior, posterior, whatever the vernacular is for your particular system, but on my system, it says VP. And it's that means ventricle posterior, and we're gonna measure towards the posterior part of the downside, and we don't want it any larger than about 10 millimeters is the upper limits of normal. And we can label that as well, although it's labeled here with the measurement. It's a little redundant. We can see what you would be on the lookout for if it was too big. Since the choroid is gravity dependent, and even though babies are in somewhat zero gravity, within that ventricle we would see it dilated, and the choroid, which is the hyperechoic area within the ventricle where cerebral spinal fluid is made, it becomes dependent, and we would actually see it dangling inside the ventricle. Now we're just going to continue on scanning, and I'm going to look for my landmarks to measure my biparietal diameter. Now, this baby's head is tucked, but as we can clearly see, we can see the atrium, the cavum septum pellucida, the falx cerebri, and the thalamus, which are our landmarks for measuring the biparietal diameter as well as our head circumference. We're going to measure leading edge to leading edge for the biparietal diameter, and then we're just going to open up our lips and measure for the head circumference. And just keep going. I'm going to keep going down baby, and I'm going to go, there's baby's heart. We'll come back to that. I'm going to get an abdominal circumference. The landmarks for the abdominal circumference is the stomach, the umbilical vein as it comes in and hooks and joins the portal system. Now this baby is laying quite literally on the side of mom's belly, and so sometimes it's a challenge to make the abdomen completely round, but we're going to extrapolate from here. What you don't want to see in your image, you don't want to see adrenal glands, which are these structures here on either side of the spine, and certainly not kidneys. You would indicate that you're too low in the abdomen and you will undermeasure. You want to see the abdomen at its widest portion, and since the liver is the largest portion of the fetal abdomen, and where should there be any asymmetric IUGR, for example, we would notice it first and foremost here in the belly, as that's where the baby has its reserves. So we're just going to measure all around, like if we're taking the baby and measuring it for its first belt, for example. My movements are very small, and I'm going inferior to baby, which is in this case, since the baby's vertex, towards mom's head. We approach the alas, which is the pelvic wing of the baby. Now I'm looking at the spine as I go, I'm looking at the aorta, I'm making sure that the anatomy that I can see appears as it should. Now the ala, the pelvic wing, will point to the femoral head. That's how you know. We're going to measure the most anterior femur, and we're just going to measure the shaft. We're going to exclude the epiphyseal edges and just measure the shaft. Now, I want you to measure it when it's 100% as best you can, perpendicular to the ultrasound as it isonates against that bone. And that means you don't want to foreshorten or elongate it by having it off angle like this or like this. Because even from here, it's just a matter of rocking your transducer ever so slightly, even when this baby is very active, and thankfully we have CineLoop that we can go back and get it as straight as we possibly can. If you don't have CineLoop, then I'm sorry. But CineLoop is extremely useful. As you can see, I am not paying attention to what my hand is doing. I'm paying attention to what this baby is doing because I know the image I need to get. I want shadows on either side of the bone. I know that I'm getting as 90 degrees to this bone as I possibly can. And then I'll measure the femur length. And so I'm going to ride my caliper up that shadow on one side and the other. And we're getting, so now that we've done a basic fetal biometry, it gives us the estimated fetal weight, which in this case is 215 grams or 8 ounces. The baby weighs half a can of Coke. Our average gestational age is 18 weeks, 1 day. Based on an early ultrasound, she should be 18 weeks in 3 days. And on ultrasound, we call that sonographically within normal limits. Now, while we're down here, a fun note is looking at fetal gender. At 18 weeks, and this baby's legs are a little closed, but we can see the external labia. Just be very careful because babies do have hypospadia and can also have this appearance. But we have these 3 bright white lines, which is hard to appreciate here. And so at this point in time, although I always caution my patients to not paint anything, it looks at this time like it's a girl. And I usually write something like, today it's a girl, because tomorrow, you know, it might grow a penis. And these white lines is what we're looking at. One, two, three. So it's the labia, the external vulva is what we're looking at, and it's the labia and the clitoris that we're seeing. And you just keep looking. Now that we have the biometry done, I'm gonna go and I'm gonna look for the kidneys. And we're just going to do a basic anatomy scan. And the kidneys are slightly hypoechoic to the liver, or about the same. In this case, we can see that they're hypoechoic, and that's perfectly normal. We see no fluid collections around it, as we should not see that. The kidneys should just look like kidneys. The baby's bladder should also be visible by this point, and if it's not, just wait a few minutes. It will fill up. She has recently peed. The black that's all around babies is the amniotic fluid, is what we call it, as a fancy name for fetal pee. Because that's the principal makeup of amniotic fluid. So this is the fetal bladder. And if you think that they're gonna have a hard time seeing it, you can always point it out right here with your little trusty arrow. Now we've already demonstrated situs. Now, if you want to, you can decrease your pi, or your field of view, so that we can increase our frame rate, and we can just simply put on the screen vertex stomach, or some abbreviation thereof, and heart, so that they know, whoever's interpreting this, that we have looked and that the heart and stomach are on, they have their appropriate situs.